Hi, everyone. My name is Tina Kaysen, and this is my week 12 presentation. And week 12 is over primary prevention clinical strategies. And according to the syllabus, that covers 3 chapters, 15, 16, and 17, and the Miller Carrol book. So a quick overview, 15, 16, and 17. Some of the things that I will be talking about are critical aspect of treating substance abuse use disorders is pharmacotherapy. So essentially using drugs, um, prescription drugs, um, for treatment of substance abuse. Personalized strategies and ongoing research have the potential to improve results. So it's essentially saying that we need more research. Future directions, improving patient treatment matching and addressing compliance difficulties. Spiritual and religious groups have a significant impact on how drug abuse is treated and prevented. Recognizing the variety of viewpoints and methods used to treat substance use disorders. Summary of how social science fields and the helping professions regard mutual aid in organizations and religion, dealing with the conflicts and rivalry that exist among research communities. An understanding of the intricate connections between spirituality, religion, and the prevention and treatment of drug abuse, the significance of additional study and evidence-based methods for comprehending and resolving these problems. So the next page is just talking about an overview. This is an overview for chapter 15. Understanding of the necessity of additional study in cooperation with religious institutions, a focus on identifying and meeting the spiritual needs of patients under treatment and rehabilitation. Effectiveness of various treatments have been demonstrated for marijuana, alcohol, opioid, and amphetamine dependence. Extended outpatient treatment durations, pro-social behavior reinforcement, individual counseling, appropriate medication use, and involvement in aftercare or mutual support groups are all related to improved outcomes. So it's generally saying that for somebody who is addicted to substances, particularly somebody who is addicted to substances and has co-occurring conditions such as depression, anxiety, bipolar. So they say they, have depression and they are also um, addicted to and abusing alcohol. Well, we know that alcohol, if you are drinking a lot and you suddenly stop, that can cause seizures. So we have to get like the medical community involved. And then we're dealing with the physical addiction to it and the physical dependence to it. So incorporating all those aspects is very challenging because substance abuse really has a hold of you. A lot of times people start using substances because they are trying to feel better and they want to feel normal, that sort of thing. So they start using, or maybe they just use, socially, and then all of a sudden they become addicted to it. And now these other complicated factors are at play, such as, dependence and withdrawal. And now all of a sudden they're using whatever substance they were using just to feel normal so they don't get sick or whatever. And so what this is saying is in order to successfully stop using, like long-term success, you need to have more than just one treatment. So like an alcoholic can't just go to detox, detox for a couple of days and then, oh, okay, all better. So somebody with alcohol abuse would need detox, medical, like they need to be medically evaluated to make sure that they're not having seizures, that sort of thing. Because detoxing from alcohol in particular is extremely dangerous. And then, they need to learn how to live again. They need to learn how to live as a sober life. They need to learn how to still start dealing with those feelings and thoughts and memories and all of those things. They need to deal with it in other ways than just using the substances. So they need to start learning and using coping skills and, becoming part of different groups. And they essentially are creating a new identity, and that's an involved process. Um, so that's really the point that this is getting at here. Stopping using substances takes more than just taking a medication to stop using it, or more than just detoxing, or more than just going to AA alone. It's a very involved process in order to have long-term success. So chapter 15 goes over pharmacotherapy, and pharmacotherapy is for drug use disorders. Uh, so some of the drugs that chapter 15 talks about are disulfiram, naltrexone, and acamprosate. So I admit I'm not the best at pronouncing that, but I don't even know if medical doctors can even pronounce all these things the best. So some of the difficulties are adherence, patient approval, and security worries. So for disulfiram, the mechanism of action is the agent that sensitizes to alcohol. So it helps you quit drinking. Restrictions, erratic reaction, unfavorable occurrences, and problems with conformity. Clinical trials, limited effectiveness in the absence of oversight. So while this medication can be positive, it also has a lot of negatives. So the next drug is naltrexone. The action mechanism is an antagonist opiate. Clinical evidence lowers rate of heavy drinking and higher rates of abstinence. Adverse effect, headache, nausea, limitations, moderate effect, magnitude, and hepatotoxicity at large doses. So staying on the hepatotoxicity, that means that this drug in a large dose can be toxic to your liver. And more than likely, you've already damaged your liver if you are using substances such as drinking and you're addicted and say you've been abusing it many years or whatever, there's a good chance you're already developing some alcoholic liver, fatty liver, and now if you're taking this medication, it could make it even worse. So that's definitely a side effect that needs to be thought about, and of course talk with your doctor. The camprosate, N NMDA receptor modulatory actions are the mechanism of action. Clinical evidence, modest impact on retention and higher abstinence rates. Safety profile, the most common adverse effect is diarrhea. That sounds like fun. So you're trying to, stop using drugs, and you're probably feeling bad because you're withdrawing, and you feel sick. And um, on top of all the withdrawing that you're doing, you are now dealing with this extra dose of diarrhea that comes from taking the medication that's prescribed to you by your doctor. Opioids, methadone, opiate addiction treated with antagonist antagonist treatment. Buforno. Sorry, I'm not great at pronouncing these words. A safer partial opioid antagonist, naltrexone, an opiate antagonist that causes problems with treatment adherence. Incentives. Disulfiram, possibility of dopamine regulation leading to cocaine dependence. Desipramine is an antidepressant used to treat cocaine abuse. Future directions include cocaine vaccinations and GABA agents. That's a very interesting thought. Cocaine vaccinations? Okay. Cannabis, strict pharmaceutical measures, issues with efficacy and compliance. So, going on the cannabis, of course, we all know that it's federally Scheduled 1, which means it's completely illegal. There is, according to the FDA schedule, there is no medicinal use or purpose, and nobody should be using it anywhere. But some of the states, particularly the Democratic states, just California and New York, have allowed their states to use cannabis. It started with just medical cannabis, where you had to have your doctor's prescription, and now it's recreational, where you don't necessarily have to have your doctor's prescription, and people are now growing it in their backyard. And then, of course, you have the red states like Georgia and Alabama, where um, a little bit of the oil might be okay, but the actual plants are completely there's no access to any of that. And so because the laws in all the states and federally are mismatching, that alone can create some issues about, like black market thing, and people using things instead of other things. And so just that alone can create its own problems. Combination medicine techniques, partial agnostic, antagonistic pairings, justification, and possible advantages. Okay, so side note. Why is this in our chapter, and why are we even talking about different medications and drugs? So yes, of course, it's true. Counselors, professional counselors, marriage and family therapists, we can't touch medication. We can't prescribe medicines to our clients. We basically have no biology training. We don't have training on how to give and administer various drugs or whatever. But most of the counselors go by a biopsychosocial model, and we go through a holistic model. So, we want to work with doctors, and usually when we have clients who are taking medications, they come in, they fill in the intake form that whatever medications that they're taking, and just from us having knowledge of what they're taking and for their different they're taking for. So say somebody is taking a particular drug and it's supposed to be for depression. If we have some knowledge of that, and they were misdiagnosed with depression, and we see that they're taking an SSRI, then, we can help advocate for them, and we can help them, encourage them about going to the doctor and talking about, you know, maybe something else. Because we spend a whole lot more time with clients than medical providers do. So I think that it's about the wholeness and the advocacy piece. Um, so I think that's an important reason why um, we should have some awareness on some medications, particularly SSRIs and how it's the most common prescribed. Um, and some of the things that they're used for. Psychotherapy, complex dynamics and results when pharmaceutical and behavioral therapies are combined. So that's basically just what I was talking about. Um, of course, we as therapists do not prescribe medications, but if we have some knowledge about it, we can talk to them, help advocate with them. I have a client who has complex medical issues and they are prescribed several medications every day. They have seizures and they have bipolar 1, and they also have other things. And so they take, 5 or 6 medications a day, and sometimes just they don't understand why they need to take them, or their brain plays tricks on themselves and tells them not to take the medications. So we can help advocate to make sure that they're taking their medications as prescribed every day or whatever. And that combination of, say, an SSRI and talk therapy or the behavioral therapy is more effective in treating something such as depression or bipolar than just one piece alone. So if a person is taking that medication and they're doing therapy, together, that's going to be a better outcome for them than vice versa, or one or the other. So being aware of possible interactions and how they might affect the effectiveness of treatment. So that's something that, I was just talking about. Of course, we're not medical prescribers. We don't really have a lot of knowledge of medicine, but it's in our best interest as the clinician to have a good knowledge base of varying pharmaceuticals that are used in conjunction with behavioral therapy, or varying medications that are used for somebody who is addicted to cocaine, or somebody who is addicted to alcohol. Using religion for substance abuse. Impact of religious and spiritual organizations on substance control. Analyzing the influence levels of individuals and public policy. A collection of customs and viewpoints on a higher reality. Spirituality, an individual sense of the sacred and ultimate issues, regardless of religious background. Spiritual mutual health organizations, fellowships run by peers that provide support and direction recovering from addiction. So one of those fellowships we could think of something like AA or NA. They have that spiritual component, and they are thought to be, incorporating the 12 steps, and they talk about your higher power and incorporating spirituality. And for the most part, people think of AA and NA as strictly Christian worldview. And if you're not a Christian, you cannot participate in AA. But that's not true, because your higher power does not need to be specifically Jesus. Your higher power can be whatever your higher power is, and you can still work the program in that same way. So if your higher power is not Jesus, that does not mean that you cannot participate in AA. The impact of religious convictions and attitudes and the initiation of substance use. Diverse viewpoints from Judaism, Islam, and Christian churches. Major monotheistic religions place a strong emphasis on preserving physical well-being. Organizations for spiritual mutual help. An overview of the 12-step program and how they support abstinence. So I do have a link here about American Addictions, Rehab Guide, 12-step, and support groups like Crow Blue and Crow X Dior. Sorry, I'm not pronouncing that right. Provide for therapy and moderation. Spiritual and religious groups have a significant impact on how drug abuse is treated and prevented by recognizing the variety of viewpoints and methods used to treat substance use disorders. So in some places, if the major spiritual belief believes that, nope, scratch that. I don't know where I was going with that. Okay. So chapter 16, summary of how social science fields and the helping professions regard mutual aid organizations and religion, dealing with the conflicts and rivalry that exist among research communities, an understanding of the intricate connections between spirituality, religion, and the prevention and treatment of drug abuse. Additional studies and evidence-based methods are significant for comprehending and resolving these problems. A positive correlation exists between recovery after the start of abstinence and participation in religion because of the historical influence of religion on drug control laws concerning the temperance movement is looked at concerning substance abuse and faith and how it is viewed. The influence of religious movements on public policy and attitudes about substance abuse. Better results are linked to higher levels of spirituality after treatment. A child's religious upbringing is associated with more robust spirituality during recovery. Training in cultural competence is required to comprehend religiously inclined clients for those with limited experience with pastoral counseling and psychology about spiritual or religious values to identify the significance of working with religious institutions to ensure successful therapy. So that's essentially saying, we need, as counselors, we need to take a culturally competent lens framework to work with our clients, and we shouldn't impose our beliefs and biases on the clients. So say I'm a Christian, and I believe Jesus, and say because I believe, I'm a Christian and I believe in Jesus, that means that if you go to AA, your higher power is going to be praying to Jesus and going to Christian church, that sort of thing. However, that does not mean that your clients are going to take the same view. So we need to have that self-awareness and cultural competence to not impose our views onto the client and allow the client to explore their own views and do things that are best for them without us imposing our own stuff on them. Professionals' lack of awareness because of the comparatively non-religious viewpoints, mental health professionals may undervalue the significance of faith in the lives of their clients and the safeguarding benefit of religious participation. So I think this is kind of interesting. The more I have been studying about counseling and that sort of thing, the more I see and I've come to realize that counselors, myself in particular, tends to have more of an agnostic viewpoint. You know, we think maybe it's there, maybe it's not, but show us the evidence, show us the proof. And sometimes when you think like that, if you become agnostic or if you become non-believing in something in particular, then that non-religious viewpoint um might not see the significance of faith, just as it says, and the counselor might be quick to skip over that and not really let the client fully explore uh, that part of their recovery, which of course is doing a disservice to the client. Don't put your own personal beliefs and worldview onto the client because this process is not about you, the counselor, but it's about the client. So, me, the counselor, I'm here to walk with you through your journey and, help you see things in different ways. I'm not here to impose my bias or my own journey onto you. Protective function of religion. Children, adolescents, and adults who practice religion are considerably less likely to use problematic substances. So, one of the things I wanted to talk about here is living in Georgia, a lot of churches, there's a lot of Baptist churches around and Protestant churches and um, churches, Jesus Christ churches. And a lot of the people do a lot of community work and they do a lot of service work. So the members of the churches are constantly running food pantries and they're constantly doing various community service projects, maybe cleaning up neighborhoods or, planting flowers or um, they're doing like clothes closets or they help you with different resource needs. And um, so some of those things, being of service to others is a particularly important aspect um, of faith. And when people are engaged in helping others, they are more likely to be happier and more fulfilled because, we human beings are designed to be connected and be of service to others in sort of a way. So just that alone can reduce rates of depression and anxiety and being a part of something bigger than yourself um, could be a protective thing where, you're not becoming depressed and you're not needing to drink a lot to uh, mitigate your depression, etc. Chapter 17 is developing a flexible and successful drug abuse treatment program comes with obstacles. Developing a flexible and successful drug abuse treatment program comes with obstacles. You don't say. So, developing a drug abuse treatment program has obstacles. If we were to talk out loud about what some of the obstacles could be, what could be an obstacle? An obstacle could be finding money to create this drug abuse treatment program. Could be marketing and, getting the word out and people joining your drug abuse treatment program, that sort of thing. Obstacles in the treatment environment. Despite significant scientific improvements, the public remains skeptical about the efficacy of drug abuse treatments. So I think some of that has to do with addiction is very complicated and takes a whole lot more than just one program to get somebody for somebody to get clean or stop using or whatever. So you often hear about how somebody went through rehab 4 times, and or you hear somebody say that they're just one drink away from relapsing, or um, one trigger away from using again. Um, so I think that some of that could be some of the public perception, especially if you don't have a lot of psychological training or knowledge of substances, how uh, so essentially public saying, well, why are we going to keep creating drug abuse treatment programs if, you know, they're not always successful and people are coming back 3 and 4 times, and we still have so many people, especially in the United States, that has such severe drug addiction problems. Low program engagement rates, with many people feeling coerced or compelled to seek treatment. So some of that we could talk about, um, say a 22-year-old who drinks a lot, goes out drinking every weekend, and isn't working or doing anything else, and they spend, most of the day depressed, and their their mom or their dad is yelling at them and telling them that they have to go seek treatment or they're going to kick them out. And so when they're feeling coerced essentially to go to a treatment program, then they're not exactly 100% doing it for themselves. It's like that old saying, you can lead a horse to water, but you can't make it drink. So in that case, that person, if they were only doing it for mom, is very likely or more likely to relapse and be one of those people who do the drug abuse treatment programs more than once. Considerable percentage of patients who start treatment drop out, and most of them relapse within 6 months of finishing it. So, relapsing within 6 months, I think the issue is pretty complicated, like I was explaining. Um, a lot of people, like I said, don't really fully grasp just how complicated it is. And so I think that maybe more education and awareness, um, and more empathy and compassion for people who are substance users, more compassion for people would go a long way. Closing the gap between research and treatment. There is a discrepancy between the methods used in treatment facilities and what research has shown to be successful in treating addictions. So some of this could be about money. Treatment facilities are more than likely going to be funded by Medicaid or Medicare, and um, that's lower paying, and so they're going to be paying their clinicians and employees lower. And so I think that a lot of it has to do with money and the motivation that money brings. I know that sounds really bad, but I really do think that money and treatment facilities, especially a community mental health or like a residential hospital, that sort of thing, um, are going to be doing things a little bit differently and cutting corners versus what research shows to be successful. 3 stages of care: detoxification, stabilization, focused on easing mental and physical symptoms and lowering cravings. This approach aimed to stabilize patients and preparation for later recovery. Rehabilitation aims to stop relapses, assist patients in regaining control over cravings for substance misuse, and enhance social and personal functioning. Continuing care, usually provided in outpatient settings for about a year, it offers continuing support for behavioral improvements made throughout the therapy and early relapse sign monitoring. So, of course, if we think about this, the first step in this is detoxification and stabilization. If a person comes in for therapy and they are, you know, abusing and addicted to whatever drug, they're not really going to be able to focus on their goals and their therapy, um, because their mind and their body is being clouded, and um, it essentially prevents them from getting better. So a lot of times people say that if somebody comes to therapy and they're like actively using and um, they're addicted to substances, that um, they need to go and detox before we can start doing work with them. And then, of course, there's a school of harm reduction and working regardless, and um, helping them see that um, reducing them out gradually over time is better. Several studies comparing the effects of inpatient versus outpatient therapy for drug and alcohol dependency have been conducted. Random assignment to equivalent of residential, inpatient, or outpatient day hospital treatment durations is common in studies. The goal of research is to determine which treatment environments are best for various forms of substance abuse. Establishing a system of substance addiction treatment that is both responsive and effective necessitates bridging the research practice divide, putting evidence-based procedures into action, and customizing treatment plans to meet the needs and preferences of each patient. So it's essentially saying that there is studies that have been done to see which is better, residential or inpatient, etc. Research on the effectiveness of inpatient residential versus outpatient for therapy or drug or alcohol dependency has not revealed any appreciable differences. Despite outpatient settings having more excellent dropout rates, it has little bearing on how effective the two settings are in comparison. The lack of discernible outcome variations has fueled the preference for outpatient care to cut costs. Once again, I'm hearing a theme of maybe it's about money. Engaging in peer support groups like AA or NA, patients with better abstinence records are those who attend in peer support organizations such as AA or NA, especially those with sponsors and active participation. The role of the counselor or therapist. Individual and group counseling has been linked to improved outcomes throughout therapy and after treatment. Patients who participate more in counseling activities typically experience reduced relapse rates It's unclear if patients who have a higher chance of recovery choose to participate more actively on their own or if therapy leads to better results. I'm willing to guess that therapy plays a role into that. Well, first, the client has to be willing to seek therapy, right? And, there's a saying that change is hard, and there's still a lot of stigma around therapy and seeing a therapist, mental health. Um, but I think that the clients who are struggling with addiction and, they're doing all the things, they went through treatment, taking medication, whatever, and they are also engaging in therapy sessions. I think that the support and the rapport that is built with a therapist is a very strong uh, motivating factor for the client to not relapse, sort of. I really do believe that the therapeutic rapport between therapist and client is sacred, and the rapport alone can be healing. Among patients with alcohol dependence, naltrexone and amprosate have demonstrated efficacy in lowering drinking and relapse rates. Of course, we know neither are without um, problems and nothing is perfect. Disulfiram, a medication that has historically been used to treat alcoholism, may also significantly lower cocaine consumption. Overall, additional study is required to understand better the mechanisms of action of various treatment modalities and interventions to maximize their efficacy, even though they show promise in improving outcomes for substance-dependent persons. So, like I was saying, while there are many medications and outpatient, inpatient, and AA and that sort of thing, it generally takes more than just one thing to help somebody recover and maybe not be in relapse every few months. Maybe they can, with the support of the community and the programs, working the steps and that sort of thing, maybe they'll never relapse, or maybe they'll relapse once in 5 years and then relapse once in 10 years. And then, continually with the support, they get to a better place where maybe they are no longer craving and thinking about substances. But in order to get over substances, it's a very hard thing to do, which requires a multifaceted approach. And so that's all of my presentation. And I think that it's interesting that I got these 3 chapters because a few years ago, I actually did an entire year of CEUs for counselors who want to treat addiction substances. So before looking at these chapters in the book, I already had a good solid base knowledge of different addictions and treatment and that sort of thing. And I think that it's interesting that I got these chapters in this book. And um, so, yeah, that concludes my presentation. And I'm going to stop screen sharing. Thank you for listening to my presentation, and I look forward to the comments soon.